Okay, good afternoon, Dr. Zuhr.
Good afternoon.
Nice to meet you. Today we're at the Oral Rehabilitation Congress in Guayaquil. I'm with Dr. Otto Zuhr. He studied dentistry at the University of Aachen, and he received his DMD from the Department of Maxillofacial Surgery at the Aachen University, and started to work as a dentist in München. In 2001, he received his specialist in periodontology of the German Society of Periodontology. Thank you so much for sharing with us these minutes and this interview for plusodontologia.com. We want to know a few things from your life. Can you share with us what you're currently working on, please?
Yeah, currently I'm really working on a research group that we just founded a couple of years ago, which is really dedicated to oral soft tissue biology and wound healing. So we set up, I would say, a quite innovative approach to science in dentistry. So really centered on patient demands and take quite some effort to really study, let's say, wound healing patterns in different clinical indications, starting with soft tissue autografts, starting really from the scratch, starting to explore the human palate on a macroscopic level, on a microscopic level, and even further on a cellular, molecular level, to really, just as a base, to further, continue, maybe later on also in developing soft tissue substitute materials, let's say in a very logical and, I would say, construct way to do that. So this is our main, let's say, project at the moment in types of research.
Very interesting. So what have been the latest advance in your research, please?
I mean, the latest advances, we actually performed a randomized controlled clinical trial where we compared two different techniques for gingival recession therapy with a quite innovative method to measure the treatment outcomes. This is digital technology to measure percentage of root coverage, and the technology allows us to also analyze the treatment outcomes in the third dimension. In other words, we can find correlation between soft tissue thickness that we achieved after gingival therapy to the amount of root coverage.
So you mean with digital dentistry? You scan the model and...
We scan the model. In the meanwhile, we can also do intraoral scans, powder-free intraoral scans. And interesting, because you asked me what is the latest project in our research, it's the follow-up investigations, 2-year, 5 years results. And I think this will be very interesting because for the first time, we can measure the stability of the soft tissue augmentation over a long-term run. This will be new. This has not been done so far. And even more interesting, we can see in the future if there's still a correlation between the thickness that we could achieve over all these years to the long-term stability of the treatment outcomes. Yeah, this is really quite amazing. Yeah.
What's the importance of soft tissue in the placement of dental implants in the anterior zone? In the maxillary anterior zone?
Of soft tissue management? Yeah. I think, if it comes to any reconstructive procedure, the soft tissue management is of utmost importance. No matter if you reconstruct soft tissue, if we augment mucosa, if we augment gingiva, if we augment hard tissue, the soft tissue management is the key. To control the early wound healing pattern is the key. If instead, let's say, of the non-aesthetic functional zone, we work in areas of high aesthetic relevance, it becomes even more important. Because it's not only to achieve, let's say, good wound healing outcomes, on top of that also the aesthetic outcome in terms of surface texture, color, mucogingival junction, alignment, no scar tissues becomes of utmost importance for the overall treatment outcomes. So soft tissue management is everything, It's everything to be successful in this context.
And so you think the microscope is a must, that this is indispensable for microsurgery?
If you ask me if the microscope is indispensable for a microsurgeon, I would say yes. Because the microscope is a very, very powerful tool to improve and develop manual skills. to stimulate, the brain-hand relationship, to really stimulate improvement in your manual skills. If you ask me if the microscope is mandatory in daily clinical routine, probably not at the moment, because the instruments, the microsurgical instruments, the microsurgical suturing materials that came out to be ideal at the moment for our requirements have dimensions that can also be handled with loops. So 5 times magnification, 6 times magnification is far enough for the instruments we are using at the moment. So the answer would be no, you don't need a microscope to be a microsurgeon in reconstructive periodontal and implant surgery at the moment.
When do you consider it is necessary to do a coating in gingival recessions?
Well, is it necessary? Probably treating recessions is necessary if patients suffer from gingival recessions from an aesthetic point of view. Okay. If not, very often it's just about stabilizing the gingiva to avoid further progression of the recession, and then you don't probably not need to treat the recession. It's more about, let's say, good oral hygiene, plug control to stabilize the recession. If the recession is progressive, rather increasing the width of the gingiva with free gingival grafts. So really treating the recession, in covering the recession, is done if patients suffer from it from an aesthetic point of view. And then again, of course, it's a big challenge to really reconstruct with all the aesthetic criteria of success.
It's a huge challenge.
Yeah.
So the last question, what type of approach provides the best prognosis for correcting peri-implant defects? Microsurgery or the normal approach?
I think it's not about microsurgery or normal approach. So let's see, in terms of magnification, what's good, for a gingival recession cannot be bad for a peri-implant recession. So this is not really to change something in the surgical approach to plastic periodontal surgery. But of course, if we deal with peri-implant soft tissue defects, it's very different compared to gingival recession defects, because all the composition of the soft tissue is very different. The vascularization of the surgical site is very, very different. Also, the defect configuration is mostly totally different, having huge horizontal defect components involved, and this somehow must be reflected in the surgical approach. So this means it's not that, the techniques are totally, opposed to each other, but they need to be further developed. So just using what we did in the past to treat gingival recession is not enough to treat peri-implant soft tissue recession. And there's some tendencies already, improvements that also have been published, but still an enormous need for further development. First of all, to avoid peri-implant soft tissue recession. So this is one thing, but of course also, once it has happened, to get better and more predictable outcomes compared to what we can achieve at the moment.
Okay, well, thank you very much for your time. It was a pleasure. I have always wanted to meet you. I think everybody wanna thank you.